Assalamualaikum and good morning, everyone. It's a pleasure for me to be here. First of all, thank you to the organizers, Suchi, who's been supporting my work in rehabilitation. And I'm happy to be here today. It's an honor for me to be here today to talk to you about the rehabilitation journey of one of our patients who was referred to me through Suchi. Okay, I'll be talking about Yak Kim Soon, who is here and who's going to be speaking later. Unfortunately, I don't have too many pictures of Kim Soon. I don't know why. I'm sure I've taken a lot of photos, but just can't find them. So the first meeting with Kim Soon was on the 23rd of October 2013, and he was referred to me by a primary care specialist. He was 29 years old then, and I saw him at the clinic, and the problem was he had non-healing pressure ulcers, and I was asked if I could help with the management of pressure ulcers. But Kim Soon had a lot of other issues. Kim Soon had a spinal cord injury, which he sustained like 9 years before that. He had a cervical neck injury, which resulted in tetraplegia. So he's been paralyzed from the neck downwards for 9 years prior to coming to see me. So looking at his issues, we knew we had to tackle more than just the pressure ulcers, and we organized an admission for him, and I think a couple of weeks later we admitted him to the ward. So as usual with rehabilitation, we see a patient with a problem, and then we explore the patient, the history, physical examination, functional evaluation, social assessment, and then we find other problems. There'll be more problems. And the main problem will not be solved if you don't solve other problems. And often, social issues play a big role. Let me see how I can do this. It's all right, you can see on the screen. So Kim Soon came to us with the sacral pressure ulcer, which is over here. And this is the greater trochanter ulcer, and he had two more on the other side. And these ulcers have been there for 3 to 9 years. This sacral ulcer was there for 9 years. So what did that tell me? What did it tell the team? That Kim Soon was lying in bed mostly, either on his back or on the sides. He didn't have pressure ulcers on the ischial tuberosity, which would tell us that he was sitting mostly. So probing into his history, yes, he was lying in bed. And he didn't have very much opportunity to sit. And this was over 9 years. And other than that, he had unregulated bowels, and that caused soiling to the pressure ulcer, and that prevented the pressure ulcer from healing. He had spasticity of both upper limbs and lower limbs. And the spasticity could be triggered by the pressure ulcers, and the pressure ulcers itself could be made worse through the spasticity because of compromised positioning. So Kim Soon was in this position, flex position, and that caused a lot of pressure on the greater trochanter while he was lying in the supine position. And because of the spasticity, it compromised his upper limb function. So even though he was a tetraplegic, he was able to flex his elbow, he was able to have some wrist extension, and also some finger flexion. Some, which could be trained to be functional. But he wasn't functional. It was because his spasticity was preventing him from becoming functional. So that was, so his functional potential wasn't optimized because of that. And he also had neuropathic pain, which caused him a lot of distress because he wasn't able to feel below the level of the lesion. So below the neck downwards, he wasn't able to feel anything, but he had pain, and he couldn't localize the pain. And why did he have neuropathic pain? People with spinal cord injury have got issues with neuropathic pain, and it's probably precipitated by his unregulated bowels, his issues with spasticity, as well as the pressure ulcers. So that needed to be managed. And he had equipment issues because he didn't have a proper wheelchair, he couldn't sit on a proper wheelchair, he couldn't be transferred because he didn't have carers who could transfer him. There was no equipment to help with his transfer. He didn't have a ripple mattress, and because of that, his pressure ulcers wasn't healing. He didn't have good bathroom commode equipment, so he wasn't able to get good equipments to help him with activities of daily living, such as bathing and showering, etc. And he didn't have aids and equipments to help him with his hand function. So there were equipment issues that compromised his functioning. And this is when we often hear, patient is not doing well because he's got poor social support. Did Kim Soon have poor social support? His parents, his family took care of him. They were very caring. They were supportive of him. He did not have poor social support, but it was a challenge social support. His family wanted to take care of him, but they needed to work. They're hawkers, and they needed to work long hours, and they couldn't look after him. They had a maid, but the maid couldn't work for him anymore, and that was when the problem became more worse. And the main carer during the day was his grandmother, 85-year-old grandmother. So when we probe further into the history, his pressure ulcers were worsening because he wasn't being turned regularly, and he wasn't positioned well. And what do you expect? It's an 85-year-old grandmother. So when we say poor social support, we've got to be careful with what we say. Because if you are not experiencing what they are experiencing, you cannot say it's poor social support. It's probably limited, or I would call it a challenge social support. So with spinal cord injury, what are the consequences? We see in Kim Soon, he had weakness, paralysis of the upper and lower limbs, paralysis of the body, sensory disturbance. He's got bladder bowel dysfunction, and he couldn't, he's got loss of thermoregulation, couldn't regulate his temperature. You'll see in one of the pictures that he's always with a blanket. I think he's with a sweater today, yeah. And spinal cord injury is associated with multi-system involvement. The respiratory problems because tetraplegic and there's no muscle functioning in the chest, so we've got respiratory problems. There can be cardiovascular problems as well with poorly controlled, with labile blood pressure, with a risk of developing autonomic dysreflexia or high blood pressures. There's bladder and bowel problems, and with bladder problems, there's a risk of developing kidney diseases, calculi, and renal failure. There'll be problems with circulation as well. So, and osteoporosis, skin problems, etc. So it's a multi-system involvement, and depending on the level of injury, this involvement will be different. And as you can see in the photos, the higher the level of injury, the more paralysis there is, and the more involvement there is. And this is just a schematic photograph showing in the higher the level of injury, then you are in a more disabled situation where you use a motorized wheelchair, and if the injury is lower down, then you'll be able to walk with some mobility aids. So what is spinal cord injury, and why does it cause so much disability? So it's an insult to the spinal cord, resulting in a change either temporary or permanent, and in this case it's permanent, and affecting the normal motor, sensory, and autonomic function. And if you read through the literature on spinal cord injury, you'll see it being described as devastating, catastrophic, life-changing, and it is. It's a catastrophic injury affecting physical, social, and economical aspects of a person. It results in varying levels of disability. It affects the activities that a patient can do. There'll be activity limitations in, if someone is paralyzed, patient is unable to walk. Someone's paralyzed, patient is unable to take care of himself. There'll be compromised activities of daily living skills, for instance. Some are unable to eat as well. So there'll be activity limitations. And because of this, there'll be problems with community participation. So they're unable to go to school, they're unable to go to university, unable to work, unable to have social life, unable to get married and have a family. So it affects patients greatly in many aspects. And because there's still no cure for spinal cord injury, and it's a permanent condition, it affects the long-term health of the individual. So I've put up to you the photo of the most famous person with spinal cord injury, Superman Christopher Reeves. And through him, there are so many research on spinal cord injury, and we know that cure is around the corner. We just don't know which corner. But while waiting for the cure to come around the corner, we must keep our patients in good health. We must keep our patients in good health condition so that when there's cure around the corner, they are ready for the cure. And in the meantime, we help to facilitate improving functions and maintaining the health and lifestyle. So in rehabilitation, we talk about functioning and disability, and we use this WHO ICF, it's called International Classification of Functioning, Disability and Health. And what I like to share here is we look at disability as an interaction of a health condition and the personal and environmental factors. So for someone who's got spinal cord injury, so that's a health condition, so it results in some impairments in body functions and structures, which I've mentioned just now. And these impairments affects the activities, and patients may get some activity limitations, and as a consequence, affects the participation of the patient in the community. This is greatly affected by personal factors and environmental factors. Kim Soon has got a challenge social support, has got challenge financial support, has got challenge accessibility to healthcare because it's difficult for him to go out to the hospital, to go out from his home, to get transport, to get to the hospital. There's so many challenges here. But if you put Kim Soon in another environment where there's no problem with accessibility, financial support is readily available, social support is readily available, then the disability would be lesser than what he's experiencing. And perhaps with lesser disability, then the health condition would improve. It may not reverse the spinal cord injury, but our complications will be prevented and he will have a healthy lifestyle and good quality of life. So the World Health Organization described rehabilitation as a process which enables people with disabilities to reach and maintain their optimal physical, sensory, intellectual, psychological, and social functional levels. Rehab provides disabled people with the tools they need to attain independence and self-determination. And if you ask Kim Soon, he will tell you that even though my hands are weak, my fingers are not strong, I want to try to be as independent as I can. What I can do, I want to do. And he wants to participate in education, and I think he has done that. He's undergoing a degree program. He wants to participate in the labor market, so he's working part-time and participate in civic life. So he's got some social life going on. I follow him on Facebook, so I know he's got some social life going on. So we hope that through rehabilitation, we have provided some support to Kim Soon to enable him to have a good quality of life. And as what we like to say, the fundamental goal of rehab is to add life to years and not just years to life. And in rehabilitation, we believe in this. And rehabilitation is only successful if a physician considers a person more than a diseased organ, more even than the whole person or the whole man. He must view the man in his world. So you must understand the person's personal environmental factors for you to be successful in rehabilitation. I've got some photos here of athletes, spinal cord injured athletes, and their world is wheelchair tennis. And we provide them with the opportunity to be able to participate in wheelchair tennis. The lady in the middle is quite famous in Malaysia. She's a newscaster. And that's her world. Her world is to be in the limelight, in the news. And that's her world. And we facilitate and we help through rehabilitation process to enable her to return to what she wants to do. The lady with the husband and son, if you ask her what does she want to do, she just wants to be a good wife and a good mother. She wants to be a good homemaker. She wants to be able to cook. She wants to be able to care for the family, to care for the home. And she wants to look good. She wants to look beautiful. And doesn't she look beautiful? And so with rehabilitation, we try to help them achieve their personal aspirations and their life aspirations. The picture below is me and my friend. We were doing our PhD together in Sydney Uni. So he was a physical educator, PE, exercise. So he was a physical education teacher in school. And when he became tetraplegic, could he go back to his work? He couldn't be a physical education teacher anymore. So he decided that I want to I want to be more able than this. I want to do more. So he did his master's and he did his PhDs, now a professor in university in exercise physiology. And that was us in Denver, America. We traveled from Australia to Denver to present our papers. And the other one, Kim Soon knows him very well, and that's Rizal, also a tetraplegic, one of our patients. And we took care of him from the time he was a degree student, and he didn't have any rehabilitation. And during semester breaks, what he did was he checked into rehabilitation. And over 4 years, he has become independent. He's decided to do his master's. That was him at his graduation last year. So these are the different worlds that people with disabilities are in. And through rehabilitation, we hope that we can realize their potential. So what are the approaches in rehabilitation? Approaches to maintain and improve medical condition, because that's very important. To enable the patient to function, they must be in good shape. Approaches to prevent, minimize, and reverse complications. With the pressure ulcers, because of the pressure ulcers, there were a lot of things Kim Soon couldn't do. So this is very, very important that you prevent complications. We've had patients with young patients, good potential, but they have got renal failure. And that compromises their potential to be independent and to realize their full potential. Approaches to reduce disability, to prevent the loss of function, to slow the rate of loss of function, and maintain current function. And we look at approaches to acquire new skills and strategies which will reduce the impact of the disability through rehabilitation, active rehabilitation, equipment, etc. And like what I've put here, compensation for loss of function, improvement or restoration of function. And finally, it's very, very important, we look at approaches that help alter the environment, both the physical environment and the social environment, that can promote activity and participation in the patient. So we admitted Kim Soon, and this was the rehab team that looked after him. So, and it's an interdisciplinary team, and it comprises of different professionals looking after a patient, and we work via teamwork, and we assess and treat the patient separately with discipline-specific goals, but involving group decision-making and group responsibility for overall patient management. And the patient, most importantly here, the patient is an active member of the team. So the patient is involved in decision-making and goal setting as well. So we assess, we set goals, and we outline the treatment plans, and we implement. And then we review. Sometimes we set the goals too high, and we have to bring it down. Sometimes we undermine the patient, so we set the goals low, and we have to bring it up. So with Kim Soon, we had our set of goals and our treatment plan. And it's always patient-centered process, so not everybody have got their own individualized program. So with rehab management, it goes through a few phases. Phase 1, we look at the problem, we manage the problem, and we do preventive rehabilitation approaches. Phase 2 would go into the active rehab, and Phase 3, we look at community reintegration and long-term health management. With Kim Soon, we realized that we set goals, and these goals may require more than one setting to achieve, and what we've been practicing is we have goal-specific admission. You may not be able to solve all the problems in one admission, so we have goal-specific admissions with different approaches. So the first admission was looking at the immediate, intermediate goals. You had to assess neurologically and also functionally, do goal setting, medical management, patient education, and do a social assessment. And because he's got poor hand function, so we look at the possibility of having hand surgery. We work with our hand surgeons, and we look at what would be the best option to improve his hand functions so that he can do more with his hands, so that he can perhaps do wheelchair transfers. And all this because we want to look at the long-term goal, which is to go back to school, in this case university, and to gain employment. So we use ICF to do our assessment. So we look at the neurological evaluation through the international standards of neurological classification or spinal cord injury. We use ICF to assess impairment and disability, and we do a social assessment so that we can improve and also facilitate the social support. And we set our goals based on his needs. Medical management at that point was to focus on wound management and focusing on optimizing spasticity and pain management. I forgot to put bowel there, and also to help with bowel management as well. And the other one was to improve function, assess and prescribe appropriate equipment that can help him to improve his function, and all this through active rehab planning. And then we look at preventive strategies as well to minimize complications through patient education and for provision with equipment, appropriate equipments. And just some photos of Kim Soon undergoing rehabilitation. And we focus a lot on upper limb exercises. But even though we were focusing a lot of upper limb exercises, you can see here, we are also looking at improving sitting tolerance. In the beginning, Kim Soon couldn't sit upright. He would get very dizzy when he sat upright, and that was because he was very deconditioned. He wasn't used to sitting upright. So we had to gradually tilt him and get him to be in an upright sitting position. And that facilitated his activities of daily living, for feeding, grooming, and helping himself in the bathroom, etc. And so a lot of activities focus on this. And we do a lot of social program in our department. And that's Kim Soon attending one of the social programs we had. And I'd like to show some of the active rehab pictures, programs that we have with other patients. As I said, the level, depending on the level injury, the disability will be different. And so there's individualized treatment plans. So for those who are able to walk, there's a gait training involved. For those with poor hand function, we focus on hand functioning exercises, and also, as you can see, things such as helping to teaching family members to learn how to transfer. It's really, really important, things that you and I take for granted. So these are the things that we do from day-to-day basis, and working in the kitchen as well. So you can see that, and wheeling the wheelchair. Not all lands are flat, so we teach our patients how to overcome obstacles as well. Some other photos, spasticity. We've got a pool. It works well for patients with spasticity, and we try to do as much as possible. You see a patient in a standing wheelchair there. This patient had pressure ulcers on the ischial tuberosity, meaning that we were not allowing him to sit, but he wanted to get around, and we wanted him to stand as well. So we use a standing wheelchair so that it can relieve pressure, and it can help him to move out of the hospital, out of the ward. And patient education, showing what the different types of cushion and the importance of having wheelchair cushions while sitting. That's also very important. And patient education is such an integral part of rehabilitation. And we get a group like this so that there's also sharing of experience as well. And the little photo that I have is one of our patients who's quite a genius with making new things, and he's showing a tool that he created so that he can use his mobile phone, because he couldn't do this, so he's got a U spleen, and what he did was he put like a pen or something, and then he used that too, so that he can press on his phone. So that's very, very clever of him. And more photos, we use technology, we use virtual reality, and we use electrical stimulation, and we do standing programs for patients. And this photo in the middle, oh yeah, I can actually use this. This photo in the middle, we are trying to, he had some weakness around the shoulder, and he wanted to be independent in transferring, so we were focusing on the muscles that were weak so that he can do independent transfers. And this patient here, at that point, he wasn't able to even flex his elbow, but he wanted to find ways to move independently. And you've seen motorized wheelchair, and you need to control it with your hand. So with someone who can't control it with the hand, so you have to find other ways. And for this patient, we were trialing out a motorized wheelchair that used facial muscles to control. So with technology, with the right equipment, so you can enable patients and you can facilitate patients to do more. These more pictures of some of the rehab program that. So we incorporate play, recreation into rehabilitation as well, so that it's not boring and it's fun. And This is a more advanced active rehab program where patients learn how to go against obstacles. And so we've talked about phase 1, phase 2, final phase, health maintenance and community reintegration. So we prepare patients towards community reintegration, driving, that's a driving simulator, sports, going to the supermarket, that's patients going to Tesco, playing pool as a form of recreation, attending conference, and that's one of the patients, tetraplegic patient who actually went for a scuba diving program. And as I've mentioned, spinal cord injury involves multi-systems, and patients are at risk of developing many complications in the first years and also in the later part of the years. And health maintenance is very important so that complications are prevented and patient has got good health and have got a good quality of life. And studies have shown that exercise is the only known intervention other than prevention of, other than risk management, post-spinal cord injury for long-lasting effects on health and functioning. So this is one of my areas of research, and we are promoting physical activity and exercise for people with disabilities and spinal cord injury. And with exercise, it also provides opportunity for socialization and community participation. So it's not just about health maintenance, but it's about community participation of the patient. So regular follow-up for optimum health maintenance is essential for the promotion of healthy aging and spinal cord injury. People with spinal cord injury are living longer and longer. They are reaching up to about 90% of the life expectancy of the general population. Through regular follow-ups, we can reduce complication, we can optimize long-term management of healthcare, prevent rehospitalization, improve quality of life, improve community participation. And it's essential that everyone needs to be on follow-up. And we are very thankful to Suchi for providing that aspect of social support, because without such social support, some patients may not even be able to come back for follow-up, may not even be able to come back to see the doctor to look at what's wrong with them and what can we do, and whether the patient needs anything more. And with Suchi, they've been able to get Kim Soon to attend programs such as this youth camp, and this was, I think, Kim Soon going to university, transferring into the car, out of the car to get into programs that Kim Soon was attending, and again participating in community programs, which otherwise he would not be able to participate in because he's at home and unable to leave the house because it's accessibility of inaccessible transportation. And I like the saying by Hippocrates, and it says here that one might say that such matters are outside the healing heart. So it's a spinal cord injury, it's incurable. These patients are going to be paralyzed forever. Why bother? Why trouble one's mind further about cases which have become incurable? And Hippocrates said, this is far from the right attitude. The investigation of these matters too belong to the same science. It is impossible to separate them from one another. These are human beings we're talking about. And this is Kim Soon's poster, which we put up last year during World Spinal Cord Injury Day in September. And our theme was My SCI. And we invited about 20 people to put up posters on the story of the SCI. And this was Kim Soon's story. And Kim Soon's bad days, the dark days, and then current, the dream, and what he's doing now, and what he wants to do, and what he feels that he can do. And I think through the rehabilitation process, he's able to achieve his ambition. And this is actually not my last slide, it's my second last slide. The last slide is actually a video, but the last slide, this second last slide I would like you all to see this, and this is what Sir Ludwig Gutmann. He is the founder of spinal cord injury rehabilitation. He's the founder of Stoke Mandeville Hospital in the UK, where they started comprehensive spinal cord injury program, and he was the founder of Paralympic Games. And he said that spinal cord paralysis is not the end of life. It is a beginning of a new life. And you can see this guy speeding away. And this is what we hope our patients to do. And I end this with a video from WHO. And this was just